And here we go. All right, we are live. Welcome back, Greg.
Hey,
it's good to be back. I'm excited for this episode of Healthier Ever After. Before we get started tonight, just another reminder, we are medical providers, but we are not your medical provider. We encourage everyone to seek medical care from your own healthcare professional before starting any health regimen, exercise plan, vitamin supplements, or medication. And that's really so that you can, be monitored well for that. What we do here is educational, informational only. So please check in with your regular provider, and then we'll get going for tonight. I'm super excited. We've got guests tonight. We've been talking a lot about some GLP-1 medications and things. And tonight we've got Cliff Holt with us. Cliff is owns a few pharmacies.
Yeah.
And not just the regular pharmacy. We'll talk, I guess, a little bit. Maybe we'll get into that on a next episode on what exactly is a compounding pharmacy. But Cliff, tell us a little about yourself and kind of your pharmacies, and then let's talk about GLP-1s a little bit, their story, and why that's such a big deal right now.
Yeah, well, it's good to be with you, Greg and Rick. I admire you guys. I've known you guys for several years, and you guys do a great job. I've been a pharmacist for a long time. I always wanted to be a pharmacist. And so I was like the youngest graduate at the University of Utah. Got out of high school at 17, went right to pharmacy school, got out at 22. And so I'm passionate about this. And I've worked at a hospital. I've worked for chain stores. I've worked for independents. I currently have 4 independent pharmacies. Our big one is Hurricane Family Pharmacy. And then we have a couple in St. George and one up in Price, Utah, which is the old mining town east of Provo. And so the Hurricane store is a retail and a compounding store, both non-sterile compounding and sterile compounding. So that's what we do.
Okay, so just real quickly, what's the difference between what you would say just a retail pharmacy, regular old like Walgreens, and a compounding pharmacy?
Yeah, that's a good question. So they look the same at the very beginning. When you walk into our store at Hurricane, it looks like a regular pharmacy. There's drugs on the wall. So a retail pharmacy, we carry commercial medications, which means they're made by Big Pharma. Right. And we probably have 1,000 different medications in the pharmacy. And we hope that, and the doctor hopes that when they prescribe something to their patient, it's going to be the right drug and the right strength. Now, a lot of times that doesn't work. I mean, any drug, I think the drug that has the most strengths would be like Synthroid, levothyroxine, and it comes in like a dozen strengths. But a lot of medications, the commercial medications, come in 2, 3, 4 strengths. And you just hope that fits the patient. And as you know, as providers who have been prescribing for a long time, that doesn't always work, right? There's
Correct.
A lot of exceptions. And it might be we need a different strength, we need a different flavor, we need a different dosage form. And so that's where compounding comes in, where we use art and science, really put them together and create customized medications. So there might be the same active ingredient that it is in a commercial medication, but we might have an autistic child that can't have anything with a red dye in it, or they need a special liquid and it needs to be a special flavor that it can go with them. It might need to be something made in a cream form, a topical form, or a suppository. We even make lollipops with medications in them. To really, the goal is to get the medication into the patient to get the desired result. And so we always joke with the providers, hey, if you can think of it, we can make it.
Yeah.
And if you can't think of it, we'll help you with that too.
Awesome. Okay, well, that's good info. That's good to know. That's super cool what you guys are able to accomplish and do. So let's talk about GLP-1 specifically. They a lot of people, I think, don't realize that this is not really a new medication. Like your semaglutide, they've been around for a couple of decades, right? And so why tell us kind of walk down that path, like how that went from obscurity, maybe, or essentially a diabetes medicine, and then how it's become just all the rage.
Well, this is a funny one. So most medications, in fact, all medications at the very beginning are usually found in nature. Aspirin from tree bark, right? And so we don't make aspirin that way anymore. Now what we do is we synthetically make it in a laboratory. But when that chemical first comes out back in the olden days, and I talk about olden days being back at the beginning of time, drugs were around then. We used medications back, thousands of years ago, but they were from nature. And so what happened was in the 1980s, they started actually studying a compound that was in Gila monster venom. You guys might have heard this story before. That's where GLP-1s came from. And so back in the 80s, we were looking at this compound, and they look and they see, okay, what parts of the body does this chemical affect? And they found that it affected blood sugar. And so then they start going, big pharma says, okay, we're looking for a blockbuster drug here. And so they're going to go and they're going to take this naturally occurring substance and see what they can do and refine it, maybe change the chemistry of it a little bit. And that's what they did in the 80s. And the first GLP-1 medication, the brand name was Byetta. And Byetta came out in the market, I think, around 2003, 4, 2005. And that was the first GLP-1 medication that came to market. Now, big pharma, it takes a while to get a drug from research phase to market phase.
Right.
And it takes hundreds of millions of dollars literally to do that, with all the research, all the drug studies, phase 1, 2, and 3 clinical trials. And so once they do that and it takes off, then what happens is all the other big pharma companies want their own blockbuster drug. And so they'll tweak the chemical and make what's called a Me Too drug. So where Byetta was the first one, then you get Victoza coming on the market, liraglutide, and you get some of the other ones like semaglutide coming on the market, which was under the brand name with Novo. It was manufacturer brand name Ozempic. And then you get Lilly coming out with their version, which is tirzepatide. And if you looked at the chemical structure, these drugs are all very similar, and they're just a little tweak of a molecule on the end of the drug chain to make it so they can get a patent on that, which is important. They get an 18-year patent, which starts at the beginning of phase 3 clinical trials. So they don't have a full 18 years. They usually have a dozen years, maybe 14 years, where they can be exclusivity on that chemical, and they can charge what they want. And they do charge what they want.
Yeah.
And that's a whole other ballgame about how big pharma prices drugs in our country, which is different than anywhere else in the world. We'll talk about that some other time.
Yeah.
But anyway, so all these 5 or 6 companies now want this GLP-1 drug. They want a Me Too drug because they can see that diabetes, here's the crazy thing about diabetes. A fourth of our country has diabetes that know about it. That's not the bad news. That's the good news. They know about it. The other fourth of the country has diabetes or prediabetes, and they don't know about it. And that's where the damage is being done to the eyes and the nerves and the kidneys. And what happens is they find out 10 years down the road, and the damage has been done.
Yeah.
Right.
Yeah. Unfortunately, they find out a lot of times when they end up in the ER with us when we're working there, and by that time, significant damage has been done to the coronaries and the kidneys and the eyes, and they didn't even know.
Yeah, exactly right. The damage has been done. You guys do a workup, and lo and behold, full-blown diabetes, right? And so now we're trying to treat this disease and all the trying to figure out what we can do with the damage has been done, right?
Okay, so I don't know. I don't know where our listeners are on this. I'm still kind of stuck back on, like, how does this conversation happen in the 80s where somebody's like, hey, you know what? I'll bet there's something in that Gila monster
venom
that can cure diabetes. Like, I don't know how that happens, but I'm glad it does.
If you go back to the drugs, there are some crazy, crazy stories about where we get compounded, where we figure out this medication, this chemical structure, right? And it's a lot of them are plant-based, right? A lot of them came from plant-based. Now, some of them came out just in a laboratory, and they figured, hey, we could do this like statins. We use those for cholesterol, right? Nobody's taken a statin because they have a statin deficiency. That's not a naturally occurring substance in our body. Yet that's the best practice, right? If you have to prevent coronary blockage, and so with high cholesterol, with lipid levels. So, but there's some crazy things about a lot of our drugs came from nature and from weird sources. I mean, rapamycin. That's another. We ought to have a podcast on rapamycin. That's an incredible drug for anti-aging, and I'll tell you that came from the Canary Islands, right? And it just stumbled across this. Anyway, that's another story for another time.
Yeah, no, it's fascinating to me. It's fascinating. I actually had a professor in college, Dr. Paul Cox. He was a botanist, and he went on a sabbatical as a PhD and for like a year or two in Samoa, and just was like the understudy for the island witch doctor, for lack of a better term, that had 3,000 years of communal experience working with plants and compounds that are all just from the island, from nature. And there were some just amazing things and things that were effective against certain cancers. I mean, it was just fascinating. How
the Amazon forest has a lot of drugs come from there, and a lot of answers are still there we haven't found yet, right?
Yeah.
Yeah.
So we got Gila monster stuff into some big.
Now, hey, just let me time out here for a second. I don't want any of our listeners to think that semaglutide and tirzepatide are made from Gila monster venom. That is not. Please let me be very clear about that. These are These are chemicals. They're made in the lab, right?
Yeah. So, but they have been around for a long time now. Like 2003, yes. Like you said, right? So people use that for and specifically for diabetes. Like the FDA approved this for use in diabetics. But then what changed over the last few years that brought these things to such the mainstream and with weight loss? Like how did we get this medication designed to help with blood sugar now is all the rage for skinny?
So it's funny. A phase 3 clinical trial to get the drug on the market usually involves 3,000 to 5,000 patients. And you think that might be a lot, but that's not a lot.
Yeah.
And so during those trials, they have to list every side effect that the patient says they think they have. And that's why every drug on the monograph says it can cause a headache and diarrhea and constipation. Now, how can a drug cause both diarrhea and constipation? There's a lot of things that cause those, but people, if they report those, the drug company the FDA requires them to list those as side effects. So what happens is these 3,000 to 5,000 people, they have a pretty good idea of the side effects because it's a double-blind study, which means the patients don't know if they're taking a drug or a placebo, which means no drug.
Right.
And the clinical staff doesn't know either. So there can be hopefully there's no bias on this. So if we're in the drug study, Rick, Greg, and Cliff, and we're all three on a drug study, and actually I did some of these when I was at the University of Utah. They had drug studies on the weekends. We get paid to go in and take ibuprofen and watch football, just look at side effects. But so anyway, we do this, and so you might be taking the active drug, you might be taking just a placebo. So it's pretty clear on some of the most common side effects, like nausea and vomiting. A placebo isn't going to cause that. And so you get a side effect profile. But let me tell you, when 1 million people get on a drug or 2 million people, then you dial in what the true side effect profile is. And you also dial in how effective this drug really is and a lot more information on dosages, right? When the drug first comes on the market, we have an idea. You get a few million people on it and we have a really good idea. So that's what happened when these drugs came out. They're super expensive, right? They've been, when Byetta came out, it was a $500 a month drug, which in 2005, that was a ton of money.
It's still a ton of money.
But it's not $1,200 or $1,500 like it is now, right? Yeah. So it's still super expensive. And so there were things on the market that were a lot cheaper. And so most providers will do step 1, step 2, step 3, and then this expensive one will probably be step 4. And so this was a real slow increase on the GLP-1s. Started getting some press. We got 1 million people on a couple of them. Victoza came out. We started seeing, wow, these drugs really are lowering A1Cs. These things are working for diabetes. Now, how did they become skinny drugs? So the number one side effect, the most common side effect, was weight loss. And it wasn't even like it was close to number 2, 3, and 4 side effects. Weight loss was a side effect. And this happened before. This happened with Pfizer, with Viagra. Viagra, before it was an ED drug, was a blood pressure drug.
Right.
It worked really well at 20 milligrams. What was the number one side effect? We all know what that was. And so all of a sudden, there's some brilliant guy in the marketing department at Pfizer that says, hey, let's market it for this. So The blood pressure drug, they just left it on the shelf, and people used it for that, but not really a lot.
Yeah.
They started going with ED at 50 milligrams and 100 milligrams Viagra, and started jacking the price up to $10 to $20 a dose, and that's how they made billions of dollars on that drug.
Yeah.
With a side effect.
Okay, so we just over time, enough people got on this and noticed that the most common thing that was sort of side effect that was happening is they're losing weight. Not only are they controlling their blood sugar better, their A1C is going down, their diabetes is getting better control, but they're losing weight.
And our type 2 diabetics are almost always overweight, right? That's part of the issue. We're insulin resistant.
I was just going to say that.
Yeah, Greg, say more.
It's like a perfect population. It was unintentional, but it was actually the perfect population to be able to note these side effects and be able to see the weight loss.
Yeah.
Exactly right. And it was really obvious too. These patients didn't have just 5 or 10 pounds to lose. A lot of times they might have 40, 50, even 100 pounds to lose or more. And so we were seeing the weight just melt off of them after a year, 18 months, right?
Yeah.
So here's what happened. Hollywood saw this and they started talking about it. And so all of a sudden they needed to lose 10 pounds, 20 pounds. They'd go on Ozempic. And it was diabetes only. It wasn't indicated for weight loss, but they started doing this about 6 years ago. And when a drug company is making medications, they have an expiration date on there, and the whole distribution is really dialed in. I mean, it's got to go from sourcing the raw chemicals to the manufacturer. They've got to produce the product, package the product, get it to the wholesaler, who gets it to the pharmacy, who then dispenses it to the patient after the doctor or the provider writes the prescription. So there's a lot of moving parts there, and they don't have unlimited supplies. They have projected supplies. In fact, if you get on any earnings call with Big Pharma, they're talking about inventory levels, right? And they want to bleed those down at the end of the quarter, not run out, but they don't want to have $500 million worth of drugs, stockpiled. So it's really dialed in. So it doesn't take much to short a drug or to deplete a drug's.
So essentially, the demand was artificially and very rapidly inflated by the non-diabetic users that were going for just this side effect of weight loss, and that got kind of caught on because the popularity of Hollywood or whatever. And
that was one. Hollywood was one. Functional medicine, number 2. Anti-aging, number 3. And of course, it works for all 3 of these things. And so it's very relative there. Yeah. And so perfect storm, and Novo couldn't keep up. All of a sudden, it was backordered. And we saw the writing on the wall at Hurricane Pharmacy. We couldn't get it. And Hurricane Family Pharmacy is a busy pharmacy. We do a lot of retail prescriptions, and we were having to tell our diabetics, we can't get this. And we're trying to source it from around the country, different wholesalers.
And so is this problem you're talking about, like specifically, is this kind of how I've heard some people say, I don't, I'm opposed to using these medications for weight loss because we're stealing from the diabetics who need it. Like, is that kind of how that feeling
at first? Yeah. And that was really that was an issue 5 years ago, 4 years ago, when we started seeing the shortages coming. And so here's the thing, where compounding pharmacy, and this is really an issue that we step in, and there's always hundreds of drugs that are short for a lot of reasons. FDA goes in and closes a manufacturing plant down in Puerto Rico. They close a chemical manufacturer, and 90% of those are in India and China. Making chemicals is a very environmentally dirty business, and the U.S. got rid of that decades ago, put it offshore, right? And so we're beholden to these countries, which now has some other ramifications with political and wars and things like that. But so there's a lot of things in the process that can make a drug not available, and so compounding pharmacy has really stepped in a lot of times to make these things. And they could be capsules and tablets, sometimes injectables, hospital medications, and things that have been around forever that are dirt cheap. Manufacturers aren't making them anymore. And so compounding pharmacy, really, that's one of the things we do, is we step in, not just doing customized medications like we talked about at the beginning of the podcast, but also to step in and help take care of the shortages that are in the marketplace. We can go in and make those.
And so is that, you mentioned that these companies, they invest hundreds of millions of dollars. It's very expensive to get their specific drug. They get a patent. Nobody can make it. They're the only ones that can supply it. But now all of a sudden there's a shortage. And so how's it okay, or is it legal for a compounding pharmacy to sort of mimic that or make that? Or is that, I've heard that asked a lot.
Yeah, that's a valid question. So the FDA has an actual FDA drug shortage list, updated every day. Everybody can go, just Google it, and you'll see the hundreds and hundreds of drugs that are in short supply in this country. And some of them you'll recognize, a lot of them you won't recognize. But when it's on that list, FDA says compounding pharmacy can step in and make those, even if they're under patent, like semaglutide and tirzepatide have been. Mm-hmm.
So that's how you then, as a compounding pharmacy, that's how you fill that demand gap, essentially.
Correct.
And allow the medication to get to, first and foremost, the people who need it for their diabetes, and second, then the wannabe skinnies, I guess, is how it's
wannabe skinnies. So here's the thing: we couldn't get this about a little over 4 years ago. We saw the writing on the wall. So I started trying to source the chemical, and that was not an easy thing to do. And so I found the manufacturer that made it for Big Pharma, and talked them into selling me some. And so we started doing our whole. We don't just whip it up and make it and sell it. We have to figure out the chemistry. We have to figure out stability. We have to figure out preservatives. We have to figure out, there's a lot of things. And then we have to test what we think is right for potency, for endotoxins, for sterility. And so that's about a 6-month process generally. So we started doing that right away before it was even on the shortage list, because we thought that this was probably going to happen. And it was, fortunately, we were ready to go. When this got on the shortage list, we were ready to go at Hurricane. We started making it, and people from across the country were asking us, "What are you doing, Cliff? How are you doing this?" And it was just a lot of luck, actually. Good timing.
It's awesome. Yeah. So okay, that's awesome and helpful. And how long does that last? Like, does it get to the point where, okay, the FDA would say, well, all right, we've got this being made enough, and now there's not a shortage enough? I mean, does it fluctuate like that?
It can. FDA doesn't want to do that. And so here's the thing. We probably ought to talk about FDA for just a second. FDA, the Food and Drug Administration, was created to control Big Pharma. And they regulate Big Pharma. They don't regulate me. Now, there's some rules I've got to abide by, but we're regulated as pharmacists and pharmacies and doctors and nurse practitioners and PAs. We're regulated by the state we're practicing. So The state of Utah, the Department of Professional Licensing regulates us. They inspect us, they license us. In fact, we just had a huge inspection last week with Doppel coming in to the Hurricane store. And it was great. They come in, they learn something every time they come in, because we're kind of ahead of the game on everything.
Yeah.
And
Zach said you guys did fantastic.
Oh, yeah. I mean, here's the thing. They come in, they're going to usually write you up for something. Couldn't find anything. So it was, and look, I'm not bragging here at all. I'm telling you, we've got great processes and we've got great people, and we follow those processes, and we don't take shortcuts. And that's why they like to come in.
We wanted to have you come explain some of this, because we know that about you. And
well, thanks. Pharmacies. So anyway, FDA, that shortage list, there's a lot of drugs on there. And what happened was they were getting huge pressure from Lilly to take tirzepatide off of there, because when that happens, then they think that compounding pharmacy can't make it anymore. Well, FDA took it off a little bit early, and lawsuits started firing up across the country. And quite frankly, if all the compounding pharmacies tomorrow stopped making semaglutide and tirzepatide, they'd be on the shortage list again, probably within 30 days, because Big Pharma still can't keep up with the volume that we're taking care of, right? Yeah. And then, look, there's enough business to go around. They're selling a ton of product too, but they're selling it for $1,500. We're selling it for $100 or $200, right? So there's a big difference, and we don't have all those things to pay for. So anyway, the shortage list is on there. Now, the next question really makes sense is, well, if it's off the shortage list, Cliff, how come you're still making it? How can you legally still make that? And here's the answer. FDA allows us to compound things that are medically necessary, and usually that's from a different dosage that's needed. Now, if you look at tirzepatide, the manufacturer makes 5 dosages of that.
Yeah.
And again, can we fit that round peg into a square hole? And we can't. And I'll tell you.
Yeah, that just the truth. I mean, they talk about these injectable medications, and our experience with patients is, and we've told people, we tell people this all the time, is that it's so interesting that there is, like, every individual has kind of this sweet spot that isn't necessarily one of these 5 doses. Some people have this, take a tiny little dose and have some great effects, and they take a tiny bit more and they get sick as can be. And so they have this sweet spot that does nothing for somebody else. And so it's really interesting that there is really a wide variety of what's the right dosage for any one individual.
And to add to that, kind of what you said earlier is the big pharma obviously tests only certain doses, and they have their titration schedule that is pretty rigid. And I know in my experience in using, compounding pharmacies for these medications for patients is that customization has been key. Because some patients, I really think we can all agree, as being in the medical field, is the lowest effective dose. If someone doesn't need a really high dose, then we should be able to have that option for patients to be able to use a lower dose where they're not having side effects, but they're getting the desired effects as far as weight loss or, A1C control or whatever it is.
Yeah.
That's a good point.
That's kind of how you're able to.
Yeah. And to Greg's point, we get to a therapeutic dose where the dose is causing the effect that we want. We give more drug than that, we're not going to get a better effect most of the time, but we are certainly going to get more side effects.
Right.
Those go way up, right? And so, we counsel our patients, look, when you're losing the weight, talk to your provider, but that's where we stop. And it could be anything. So instead of not just 5 doses, and if you think about a 1 ml syringe would have 100 units in a syringe, right? If we're using an insulin syringe, we don't just have even 100 different doses for our patients. We probably have about 120 doses, because now we have patients micro-dosing it and taking even less than a hundredth of a cc. And so the doses are all over the place. And you guys are seeing this too with your patients.
Absolutely.
Yeah.
That's awesome.
So compounding, really back to compounding, we customize whatever the dose needs to be. So if the provider says medically necessary, we can compound it, even if it's still under patent, even if it's still commercially available, we can do that. Now, if a provider writes for 10 milligrams of tirzepatide and doesn't put that on there, we're dispensing a brand name drug, right? Because there's no reason to dispense the compound. And we dispense a lot of the brand name big pharma drugs in the GLP-1 space, mostly for diabetics, but we do way more compounded because there's more people that want a different dose than those 5.
So someone, a patient's provider needs to be aware of that as well, of how to kind of appropriately put an order in that then would allow you to meet that need.
Exactly right. It has to say medically necessary on it.
So what about like, are there safety concerns with this? I mean, I know you've been doing a great job, and we'll talk in a little bit about compounding a little more. But what about like these research peptides? Or I can get online and get this super cheaper. Like, are there some red flags that people should look out for?
Yeah, you need to be careful of that. And we really ought to have a talk about peptides. That's going to be changing in the near future. Peptides, GLP-1s are peptides, of course, which are just blocks of amino acids put together. But there's some other peptides that the FDA put on, we call it the naughty list, about 4 years ago. We were able to compound them, and then they told us we couldn't compound. That's probably going to change here pretty quick. And so what happens is, if I order a powder, I don't want it to say research grade. That's what the labs use to do testing, animal testing, things like that. And so there's a lot of semaglutide and tirzepatide, for instance, that say research grade on it, and it's really cheap. And we're not going to touch that. Again, I told you before that we found the source that gives it to big pharma. We feel pretty good about that. There's a lot of different manufacturers of raw ingredients, the powders themselves, and semaglutide and tirzepatide. There's a lot of manufacturers in China that are making this now, and because it's gotten so big, not just in the US, but around the world. And so we're very particular, and we would never use anything that said research grade, because you're going to get somebody in trouble. Somebody's going to get in trouble with that. It's just not. Look, when we're making sterile medications, these have to be endotoxin-free powders. We need to see a lot of testing from the powder, from the manufacturer. as well as our testing as well. That research grade, you're not going to get all that. You're not going to get all that.
Hasn't been through all that same testing that you're
hasn't been through 14 different tests. Yeah. And so you got to be super careful with that. So like retatrutide, right? Lilly's new drug coming out, which works 3 ways, where tirzepatide works 2 ways, right? And so we can get that powder right now, but the only powder you can get right now says research grade on it.
Yeah.
And so that's why we get asked every day, Cliff, can you make this for us? And the answer is not yet.
Not yet.
Because we can't find the powder that doesn't say research grade only. Yeah.
I have a question. I don't want to get you too far off track. I know we're talking about GLP-1s, but what are, if you can even speculate, what would be the suspected concern with, let's say that someone does get research grade tirzepatide or semaglutide. What would you guys suspect be the biggest issue? Would it be a sterility issue? Would it be that you're just not getting the same amount? Like where would be the concern with someone getting a research grade product? I've talked to many patients that have been on the research grade, and perception wise is, hey, I'm on the same stuff. It feels very similar to me. So why not just pay $50 online and not run it through a medical provider? I think we all know the answer to that question, but their question is really like, why would I pay the extra cost to go through Hurricane Family Pharmacy or any other reputable pharmacy for this compounded when I can just get it for cheap online? Is there anything that you suspect we may not see now, but it'll come to fruition later on?
It's a great question, and there's a lot of concerns with this. One is, if we knew the pharmacy, so let me back up. You should know your pharmacy and be able to talk to a pharmacist in the lab of any compounding pharmacy. If you can't do that, then there's all sorts of things that could happen and go wrong. So no matter what compounding pharmacy you're using, you should be able to call up and talk to the pharmacists in there and ask questions. And if you can't do that, then we have a lot of concerns. Where is it coming from? And so there's a lot of semaglutide, I got the air quotes going here, tirzepatide coming in and out of the country. We've seen a lot of this stuff with no GLP-1 in it. And then we always worry about, well, is there something that could be harmful in there? Could it be not even a sterile product? If we take something orally and it's bad for us, we're usually going to throw it up, or we can at least cause that. After you push that plunger in, man, it's there. You're not sucking it out. You're not getting it out of there, right? Yeah. You administer that dose, IV, IM, sub-Q, it's in the body, right, for good or bad.
Well, you don't really have the GI tract as a filter.
Right.
Correct. Yeah, it's in there. It's going straight into the bloodstream, and then of course, eventually first pass in the liver, and but yeah, there is no barrier, so to speak. If there is something in there that, generally speaking, wouldn't even necessarily make it in via the GI tract if you put it in that way.
Correct. So I think we have to be super careful. And look, we're not talking about, the prices have come down on these things. And so there's, you can save a few dollars, but gosh, it's, and I don't want to offend anybody, but I've got friends that have gone down to Mexico and had their stomach surgery, right? To the stomach sleeve surgery. And I know 3 or 4 of them that almost died. That, it's a little cheaper. It wasn't cheaper for them. By the time they came back and tried to find a doctor to take care of them and get all taken care of, it was way more expensive. They had just done it at a place here in the US. So we've got to be super careful when we talk about our bodies. And this isn't a commodity. This is, again, we're talking art and science to make a compound. And there's a lot to it. When we're first putting formulas together, it's not uncommon for us, like Big Pharma, to have to go through 5, 6, 7, 8, 9, 10 formulations until we get it exactly right. And we're spending a lot of money testing that with a third-party lab to make sure that it's safe and it's effective and it's the right potency. And we're talking about our bodies here, and you just don't want to take chances when it comes to that. And it's not every tirzepatide, just as it says tirzepatide, does not mean it's the same.
Yeah, awesome. So that's why we appreciate good quality. We want to kind of talk about good quality pharmacies. Let's one last question, and then we'll we'll take a break and move on to some other thing on just the company in general. On the GLP-1s, there's a lot of talk lately, I think, about the oral formulations. As opposed, there's some people that don't like the idea of an injection for whatever reason. And so now there are kind of some oral formulations. Are they working? Are they helpful? Are they more expensive? Tell us a little about that.
Yeah. So semaglutide, Novo came out with a commercial oral tablet called Rybelsus, and it's been on the market for several years. And if you look at it, so most peptides get blown apart in the environment of your stomach. The acidity, they won't get through the acidity, so it blows the chemical apart, so you don't get the effect, the desired effect. So what they did is they beefed these tablets up in milligrams. So if you think about a semaglutide sub-Q dose, you might be talking about a 0.5 milligram to 1 milligram, maybe up to 2 milligrams. But if you talk about the oral dose, it starts at 3, currently goes to 17. They're coming out with a 24 milligram. And so you can see the dosage has to be way higher because a lot of that's not going to get through the GI system, the GI tract. And so because of what Greg was talking about, that first pass effect with the liver and then the acid environment blowing it apart. What's kind of confusing is, so we made a sublingual version of semaglutide, and people think since it's going in the mouth, it's oral, but there's a big difference here. And if we do something sublingually, there's a lot of vasculature in our mouth where it goes right into the bloodstream. We can absorb things in there. And so there's a lot of times we'll use a tablet sublingual, right? If we want to get it right in the bloodstream quickly, like ondansetron makes an oral tablet that just dissolves in your mouth. There's a lot of medications that do that. And so what we do is we made semaglutide into a drop that you just put under your tongue and hold it there. And so anything that's held in there will be absorbed. And so you can do a low dose. Then once you swallow it, it becomes oral. And so not much going to be affected there, right? So we can think about 3 different dosage forms currently available in the market for semaglutide. We have the injectable, which is sub-Q. We have the oral brand name medication, which is a big tablet, not a big size tablet, but a big, strong milligram tablet with a lot of drug into it you're taking orally. And then we have the sublingual version that you just dissolve in your mouth.
What's the, do you know off the top of your head, absorption wise, what you're looking at oral versus sublingual? I couldn't recall that off the top of my head. I think I've asked that.
It's about 10% absorbed orally compared to 10% of the drug orally and it could be 10 to 20 depending on different environments, but generally it's around 10% is going to get through there. And that's why you have to jack that dose up so much.
Yeah. Okay.
But is it as effective? I mean, is it helping people?
Yeah, it is. Once you get the GLP-1 in the bloodstream, it doesn't matter how we get it in there. I mean, we could make GLP-1 suppositories if you guys want to start doing that. And those are absorbed really well. So once we get it in the bloodstream, it's great. But we just have to, if we're going to do it orally, that's where we have to give the very most drug.
We're going to lose a lot of that strength.
Yeah, exactly.
Does it make it more expensive to then do it that way because you have to use so much more milligrams?
Like we could make a GLP-1 semaglutide capsule, or with our new tablet machine, we can make a tablet, but it doesn't make a lot of sense to do that because it isn't going to be a huge savings.
You're roughly 90% of the medicine that you eat.
Yeah. Quite frankly, it just makes sense to go the other way.
Yeah. Okay. Well, thank you. I think that's been helpful.
Yeah, absolutely.
GLP-1s and the history, and they don't come from Gila monsters.
Nope.
Don't get worried. There's not a big factory of Gila monsters sitting somewhere where they're extracting.
That was the 80s.
That was the 80s.
That's right.
From someone that has a more creative thought process than I do, it was probably someone like Cliff that, can really think outside the box.
Yeah. It's the chemistry thing. What's funny is when I was in pharmacy school, we had a class for a full year called pharmacognosy. Pharmacognosy is the study of weeds and seeds. And it talked about where these drugs came from originally. Wow. And it was back then, it was probably one of the most boring classes. It was the most boring class I took.
Really?
Now I would love it because now I mean, biochem was another thing. I just got through biochem. Now I'm passionate about biochem. I want to know how everything works in the body, right? And so all my textbooks, my biochem book is the only one I ever get into still, right?
Wow, that's awesome.
Yeah.
All right. Well, we appreciate it. We appreciate you coming on.
Good to be with you.
We'll wrap it up this time, but we're going to keep you on and kind of do another
Sure. Just remember, information purposes only. We're here just to provide additional help and information. Talk to your medical provider if you have any specific questions about, medications you're going to be using, treatment plans, anything like that. We are here to just be a resource for education.
All right. So we'll call that a wrap.
Yeah.
We'll clip it there, but